All right, welcome to this explainer. We're diving right into a true clinical masterclass today, looking at one of the most, honestly, intricate balancing acts in medicine. We're talking about the deeply complex, bidirectional relationship between the heart and the kidneys. I'm really excited to get into this with you because once you grasp how these two vital organs communicate and, frankly, sometimes sabotage each other, everything about managing heart failure and kidney disease just clicks. It makes complete sense. So let's just jump right in.
I want to kick things off with a pretty stark number, 50%. When we look at chronic heart failure patients, right around 50% of them also have chronic kidney disease. And this isn't just some random overlap. When chronic kidney disease tags along with chronic heart failure, that patient's risk of death literally more than doubles. So this combo, it's incredibly common, it's highly lethal, and it absolutely demands our full attention.
So here's our game plan for today. We'll quickly cover the heart-kidney connection, the 5 cardiorenal syndrome subtypes, kidney hemodynamics, a clinical vignette to test your skills, and wrap up with treatment and management strategies.
Starting off with Section 1, the heart-kidney connection, and what is essentially a vicious cycle.
Think about it. When cardiac output drops, the kidney panics and starts retaining salt and water, which then feeds right back to put even more strain on the heart. It's a devastating feedback loop. As our source material perfectly puts it, the synergistic failure of both organs together has been termed cardiorenal syndrome. Now, you might be wondering, why do they fail together so often? While beyond that hemodynamic loop, they share almost the exact same profile of cardiovascular risk factors, things like hypertension, diabetes, peripheral artery disease, and obesity. These act as chronic low-grade stressors that just set both of these organs up for dual failure over time.
And moving on to Section 2, the 5 CRS subtypes, where we categorize the failure.
To bring some order to the chaos of this pathophysiology, experts have broken cardiorenal syndrome down into 5 distinct subtypes. Types 1 and 2, they start with the heart. Type 1 is acute heart failure causing acute kidney injury, while Type 2 is chronic heart failure driving a chronic kidney decline. Now, Types 3 and 4 flip the script entirely. The kidney fails first, which then leads to cardiac injury. And Type 5? That's a systemic event, like sepsis or severe shock hitting both organs at the exact same time. But hey, I want to remind you of a really crucial clinical reality here. Patients don't just stay neatly in these boxes. In actual practice, they shift dynamically between these types. A patient with chronic Type 2 can easily develop an acute Type 1 exacerbation. Our goal isn't just slapping a label on a patient, it's about pinpointing the initiating triggers so we know exactly what to target with our therapies.
Okay, let's dive into Section 3. Kidney hemodynamics, looking at the actual mechanics of failure.
So when a patient is in heart failure, cardiac output drops, which means renal blood flow, that crucial forward pull of arterial blood into the kidney, decreases. Now, normally you'd think this would just crash the kidney's filtration system, right? But the kidney is incredibly smart. To preserve its glomerular filtration rate, or GFR, it uses something called renal autoregulation. It literally clamps down and constricts the efferent arteriole. Think of that as the exit pipe of the glomerulus. By narrowing that exit, pressure builds up inside the glomerulus, which keeps the filtration going even when the overall flow is low. It's an absolutely essential survival mechanism.
But wait, the story doesn't end with just arterial blood flow. We have to look at the flip side of the equation here. It's not just about the lack of forward pull from low arterial flow, it's equally about the backward push of congestion. In heart failure, central venous pressure, or CVP, rises significantly. And all that high pressure, it backs up directly into the renal veins.
And that brings us to what happens next. Remember, the kidney is an encapsulated organ. It's trapped inside this tight, inflexible fibrous capsule. So when renal venous pressure shoots up because of heart failure, the kidney literally has no room to expand. Instead, the interstitial pressure inside the kidney just skyrockets. This intense pressure physically compresses the delicate renal tubules, essentially crushing the glomerular filtration rate from the inside out. We call this a congested kidney. It's a striking mechanical failure, and it's driven entirely by fluid backup.
All right, Section 4, a clinical vignette on worsening renal function.
Now that we've got a solid grip on the hemodynamics of autoregulation and congestion, let's test your clinical intuition. Picture this. You're on the wards and you're managing a chronic heart failure patient. You do the right thing and prescribe a standard guideline-directed RAAS inhibitor, like an ACE inhibitor. A few days go by, you check their labs, and whoa, their serum creatinine has noticeably increased, which tells us their kidney filtration has dropped. This is a super common clinical dilemma, and honestly, it triggers a lot of anxiety for clinicians.
So, based on the physiology we just walked through, what should you do here? Option A, stop the therapy immediately to save the kidneys. Option B, double the dose to force the heart to pump better. Or option C, monitor closely, as this is an expected physiological response. Let's take a moment to really think about this. 3, 2, 1. Okay, have you locked in your answer?
If you guessed C, you hit the nail on the head. The right move is to monitor closely as this is expected, and this brilliantly illustrates everything we've just talked about. Remember that efferent arteriole the kidney clamped down on to preserve filtration? Well, ACE inhibitors physically block that constriction. They pop that exit pipe wide open again. Because of that, the filtration pressure functionally drops and the creatinine goes up. We call this pseudo-worsening renal function. The drug isn't actually causing structural damage to the kidney, it's simply turning off an adaptive mechanism. In fact, if the patient's overall heart failure is improving, this functional drop in GFR is actually associated with better long-term survival. Crazy, right? Now, it is absolutely vital that we contrast true acute kidney injury with this worsening renal function. True AKI involves actual physical damage to the kidney tissue and a severe drop in urine output. But worsening renal function from our heart medications, that's usually just a transient functional shift. Our sources tell us that an increase of up to 50% above the patient's baseline creatinine or hitting up to 3 milligrams per deciliter is actually generally acceptable. The caveat being, of course, that the patient's heart failure status, like their congestion, is visibly improving. So the takeaway? We don't panic, we monitor.
Finally, let's wrap up with Section 5, treatment strategies, and how we manage this dual failure.
When we're dealing with patients who have heart failure with reduced ejection fraction, or HFrEF, the treatment algorithm is very structured. Step 1 is getting them on an ACE inhibitor and a beta blocker. Now, if they're still symptomatic, Step 2 is bringing in a mineralocorticoid receptor antagonist, or MRA, something like spironolactone. Step 3 means stepping up and replacing that ACE inhibitor with an ARNI, like sacubitril/valsartan. And running throughout this entire process, we're using loop diuretics specifically to relieve that severe fluid congestion we talked about earlier. But because these patients have concomitant kidney issues, every single step comes with a pretty major caveat.
We have to be hyper-aware of specific renal cautions with these life-saving therapies. Like we just saw, RAS inhibitors can cause an early dip in eGFR. MRAs are fantastic for the heart, for sure, but they heavily increase the risk of hyperkalemia or high potassium, especially when kidney function is already low. Interestingly enough, ARNIs actually slow the overall long-term decline in kidney function, but they might cause an increase in urinary albumin. But here's the so what of it all. In heart failure, this increased albumin acts more as a risk marker rather than a true risk factor, because at the end of the day, survival still improves. Finally, for the most severe cases, we have to look at advanced mechanical options. Things like cardiac resynchronization therapy, LVADs, which actually help improve long-term renal blood flow, or in the most extreme cases, combined heart-kidney transplants.
So what does this all mean? The crucial point we arrive at is this: the heart and the kidney are locked in a relentless physiological dance. We really have to look past the simple lab numbers and treat the patient as a whole. Which leads me to leave you with a final provocative thought. If life-saving heart therapies temporarily mess up our standard kidney metrics, but ultimately keep the patient alive and decongested, how should we fundamentally redefine the very concept of organ failure in these deeply intertwined systems? Thank you so much for joining me in this interactive masterclass today. Keep questioning the physiology, keep looking at that big picture, and I'll catch you in the next explainer.